Now we will see how ultrasound can be used to measure left ventricle function. Left ventricle function usually is measured both as systolic as well as diastolic, and ultrasound is a very good tool to evaluate both systolic as well as diastolic function. Um, Systolic function by means of echocardiography can be done by measuring the movement of the myocardium in systole as well as myocardial thickening. Myocardial thickening is equally important to evaluate the myocardial systolic function. Um, Usually, sometimes it can be a challenge to judge left ventricle systolic function. You can see from these images, you even though this looks very simple, these images may give you a false impression that systolic function is good because the output is not optimal. You can see the first picture is absolute, there is no movement as well as there is no thickening. And the second is there is very good movement and very good thickening. But the output of both this situation is totally different, or maybe you can say totally same. The output is not there. How do you use left ventricle? How do you use ultrasound to measure left ventricle systolic function? As you know, we use only 2D imaging, and the first way one method is by calculating the ejection fraction. It is calculated by, it is a simple formula. You measure the end-diastolic volume and subtract it by systolic volume and divide by end-diastolic volume, which is converted into percentage. In our fate card, we have shown different ways of measuring left ventricular systolic function. Usually we use four different methods. Typically, cardiologists use eyeballing for measuring ejection fraction because they are used to doing left ventricle evaluation. Fractional shortening is another method where we calculate the systolic and diastolic thickening and relaxation of the myocardium, and it is used with the help of it is calculated using M-mode. Mitral septal separation is a gross method of um, uh, getting the general overview of left ventricular systolic function. It is usually used by cardiologists for prognostic purposes. That is the repeated measurements and see how the left ventricle is behaving over years. For us, it can give us just the idea of how severe left ventricle function has been damaged or reduced. MAPSE, you must have read it in our module. MAPSE is mitral annular plane systolic excursion, where you measure the movement of mitral annular plane in during systole. Let us see how we use all these methods. Eyeballing is the most common used method. As I already told you, cardiologists use it in various situations, and measurement is done for documented visual purposes and future references and future comparisons. Um, Usually in eyeballing, we advise to take all views possible, all possible views. You can see there the one view is subsequent view, other is the parasternal four chamber view, and parasternal short axis view and parasternal long axis view. And the first view is apical four chamber view. Supplementary views are two chamber view and long axis view. These are not included in our Fate module, but these are also used by cardiologists to get an overall picture of left ventricular systolic function. And if when you look towards take the general consideration of all the views, you get a better picture of how all the different left ventricle walls are contracting. You can see how the pictures say the ultrasound images should give you idea about left ventricle when it is in failure. You can see there is almost no movement in left ventricle, and there is no in another thickening. On the extreme other extreme, you can see extreme contractility and extreme thickening of the left ventricle. It is usually seen in left ventricle hypertrophy as well as in hypovolemia. Fractional shortening is another easy method to judge the left ventricular systolic function. In that, we usually take parasternal long axis view, and Tichold's formula has been used, and the machine has different softwares where you just have to put the different dimensions, so you get the figures. In that, you get a very good parasternal long axis view. You must have you will learn how to take a optimum parasternal or ideal or reliable parasternal long axis view. In this parasternal long axis view, you should have the aortic wall almost in the center, and you should not see the apex. In this case, you have to take a lot good view, put the M mode cursor at the tips of the mitral wall leaflets through the papillary muscles, and then you get a picture like this, where you calculate the distance between the endocardial borders during diastole as well as systole at the level of the papillary muscles. The diastolic level diameter and systolic diameter gives us the fraction shortening, and it is calculated by subtracting diastolic diameter minus from systolic diameter from diastolic diameter divided by the diastolic diameter. It gives a fraction, and it can be converted into ejection fraction by multiplying by 2. Um, and yeah, the fractional shortening should be more than 25 in normal cases. Mitral septal separation, as I have told you, again we have to take a good parasternal long axis view and put the cursor through the tips of mitral leaflet. It should be a little closer to the mitral leaflet so that you can measure the movement of anterior mitral leaflet. Here you'll get such picture, and you have to measure the distance between the anterior mitral leaflet and the septum during diastole, so that you can see how much the the mitral wall, anterior mitral leaflet moves towards the septal wall. It has to be less than 1 centimeter. That means during diastole the ventricle is not that much dilated. But in case of dilated ventricle, where usually the left ventricular systolic function is very poor, the anterior mitral leaflet cannot reach within 1 centimeter of the septum. And in that case, you can say that left ventricle is dilated, and which can mirror as that left ventricular systolic function is reduced. You can see here left ventricular systolic function is reduced, but there is restricted anterior mitral wall leaflet movement. So MSS is not used usually typically in cases of aortic insufficiency, because a strong jet from the aortic root goes into the left ventricle, which obstruct the movement of anterior mitral leaflet. And also in the mitral wall calcification, where despite having good my left ventricular contractility, the anterior mitral leaflet cannot move towards the septum. So my MSS is not usually reliable in these situations. MAPSE, as you must have read in our module, MAPSE is mitral annular plane systolic excursion. You know the optimal four-chamber view, apex should not move and the base should move towards the apex. And this principle is used to measure the contractility. We take a good parasternal long axis apical chamber, four-chamber view, and we put a M mode cursor line through the lateral annulus of the lateral annulus of the mitral wall, and we take a M mode picture. And here the M mode, the movement of the mitral annulus during systole and diastole, the difference is calculated using the machine software. And this should be ideally, the movement of the mitral annulus should be more than 11 millimeter for the normal. Rest of the findings are given in our FATE card. This, now we have seen left ventricular systolic function. We see usually fractional shortening, ejection fraction, and mitral septal separation, mitral MAPSE. Now let's see how we can use left ultrasound or FATE to evaluate right ventricular systolic function. Again, right ventricular systolic function can be judged using eyeballing, and another objective method of systolic RV systolic function is TAPSE. TAPSE is similar to MAPSE, but TAPSE has more global acceptance than MAPSE. And if you ask me, TAPSE is the only objective measure of right ventricular systolic function. Of course, now right ventricular systolic strain and all these advanced measurements are available, but you need very sophisticated software for that. How do you measure TAPSE? Again, you take good apical four-chamber view, For eyeballing, as usual, you take all four available views and see the contractility of right ventricle, and then you can say that right ventricle is contracting well. If you want to calculate TAPSE, good four chamber view. Here, usually we recommend to take a modified four chamber view where you move the probe slightly towards the sternum. So more and more right ventricle is visualized in the picture. And here again, the M mode cursor is put across the tricuspid annulus at the lateral side. And then you get a M mode graph like this, and the same, and then you measure distance of the difference between the points in systole and diastole. Normally, it should be more than 18 millimeter, 16 to 20 millimeter. So 18 millimeter is acceptable. If it is below 11, then it is mild reduction in left right ventricular systolic function. There are many ways we can use FATE for measuring left ventricular systolic function. In cases of post-op cardiac surgery, following cardiac catheterization, trauma, in case of renal failure, in sepsis, in these all these situations, there is a typical picture of either hypotension or shock, and we don't know what is happening, and we do we do FATE, and we try to find out what is the systolic function. Also, in cases of another situations like pulmonary embolism, right ventricular infarction, pulmonary hypertension, as well as in volume overload, systolic function measurement, right ventricle as well as left ventricle is very important, and you have to use our FATE views. These are the various situations, and all the situations are given in our new extended FATE card. Now let's see how diastolic function is been evaluated. Diastolic function is actually seen in 50% of cardiac failures. The peculiarity of diastolic dysfunction is that left ventricular systolic function is normal, but the patient is in failure. The common reason is left ventricular hypertrophy, and if you observe thickened left ventricle, especially at the in septal level as our posterior wall level, then there are high chances that patient has diastolic dysfunction. Diastolic dysfunction, I mean the left ventricular hypertrophy, in turn gives left atrial dilatation because left atrium has to contract vigorously to full or complete the filling of left ventricle during diastole, and that keeps that required force causes the left atrium to dilate. So this, if the patient has left ventricular hypertrophy and dilated left atrium, then the chances of diagnosing or the possibility of patient having diastolic dysfunction is quite high. You can see in the FATE card of that, you can see that left ventricular hypertrophy and LV dilatation. Thank you.